please welcome to the stage Alicia, Dr. Patel, and Dr. Garner.
Wonderful. Thank you all for joining us today. So as Jonathan said, I'm in medical and scientific affairs, and today I'm joined with two experts, and they're going to weigh in on their opinions on how we can bring gold standard PCR to the point of care populations that need it. So on my immediate right, we have Dr. Payal Patel. She is an associate professor at the University of Utah School of Medicine, as well as the system-wide medical director of antimicrobial stewardship for Intermountain Health, based out of Salt Lake City. So thank you for joining us today. And then we have Dr. Omai Garner. He is an associate clinical professor as well as the director of clinical microbiology at UCLA Health. So we're going to have a good conversation today about this. Thanks. Wonderful. So today our conversation is going to circle around bringing PCR to the point of care. We're kind of going to take a walk through evaluating what is the value of PCR, how it's currently being applied in the respiratory field for respiratory diagnostics. Also talk about what the future of PCR in these point of care settings is, and then hopefully discuss some resolutions that we can potentially implement for any obstacles that you might be experiencing as you're trying to bring PCR into your point of care setting. So the first question I'm going to pass over to Dr. Patel. Especially over the last 5-10 years, we've seen a huge expansion of molecular diagnostics, especially for respiratory. So can we just take a couple of minutes, tell us what solutions exist and what makes PCR the gold standard as you're kind of looking through these different options?
Yeah, definitely. So I think, especially in respiratory infections for a long time, there was a need for better diagnostics. We had, for people with pneumonia, traditionally been looking at blood cultures and sputum, with blood cultures often being 8% sensitivity if you have a pneumonia, which is not very helpful, right? So 92% of people wouldn't have something grow in their blood cultures. And so there was definitely a need for those better diagnostics. And I think we've gotten that more recently with molecular testing. But something that's still happening is trying to distinguish bacterial from viral pneumonia, and then going a step further and trying to have people stop treating viral infections with antibiotics. That's a huge thing in infectious disease. So I think right now we're really working on, we have new diagnostics. How do we implement those into the workflow of what we do in the hospital? And that's where people like Dr. Garner come in.
Nice, thank you. So the next question is that as we have all of these different options available to us, we want to make sure that we are considering all of the factors to make sure that we are developing or providing the right test for the right patient at the right time. And so I just want to spend a couple of minutes kind of talking about what are the top considerations that you have as you're developing a respiratory testing algorithm to make sure that you're providing the right option for those patients, especially in that point of care setting.
Yeah, I think we learned a lot during COVID, right? I think pre-COVID, this idea of testing everybody for a respiratory virus was fiction. And it wasn't necessary from an infectious disease perspective. But with COVID, we learned there's sort of different levels of necessary testing depending on really patient acuity. So for the patients in an outpatient setting who, let's say, require an 18 to 24-hour turnaround time, so do you have asymptomatic COVID? Do you have COVID and you need to stay away from your family and friends? But you're not sort of essentially extremely sick. That can be a high-throughput PCR run in a clinical lab. You don't need a 20-minute answer for that. So you can have all of the advantages of high throughput, it's cheap, the overall turnaround time is reasonable in that space versus inpatient, right? If I go up to Dr. Patel and I say, well, your inpatient COVID's taken 18 hours, she's like, no, it's not. So in that setting, we need a faster turnaround time for that. But in the clinical lab, we really offer that as well, right? We had a 1 to 2 hour turnaround time. Now, there's still a patient need that's even higher than that, though. The patient that shows up that maybe doesn't have COVID, but needs emergency surgery or needs some emergency procedure, and then you need a 20-minute test. And this is where I think point of care, especially for molecular, fits in really well. You need exquisite sensitivity, So you can't be calling false negatives. So antigen tests are kind of off the market at that point. And you need a test that you can rely on the results in 20 minutes. And that's where we really integrated point of care molecular testing. So we could affect that patient population positively, really by calling negative results and having them continue on with care.
Yeah, I will just add on to that. I love all of that. And from a clinician's perspective, it's always helpful to have an algorithm where, it says like, is this person under the age of whatever, 70? Do this test. If it's positive, do this. If it's negative, do this. And that's where I think stewardship programs can work with microbiology labs and diagnostic stewardship teams to really help use the test and get the right result.
Nice, thank you. So I think having your clinical perspective and the lab perspective is kind of just like a beautiful marriage of how implementation of these things can have really big impacts, right? So Dr. Patel, I know that you spoke earlier today about what some of those impacts are whenever you start implementing point of care. Or implementing PCR at point of care. Can you speak a little bit about what kind of you've seen in different health systems and maybe pass it on to Dr. Garner after about what that impact is?
Yeah, I work in a system where we have big hospitals and small hospitals. We have pharmacists on site or off site, and so the lab test result being done at a point of care would really kind of change whether you would have that information while the patient is still there, let's say in an outpatient setting, such as an ER or an urgent care, and can kind of affect the care from there. We also have like a lot of rural outreach in our system. And so one thing that we've been testing is kind of like a telemedicine ER. And so again, something that I'm thinking about is how would we use results to help an algorithm for whoever's going to get that result and get that back to the patient. And so I think that's something to think about as we move into this field of telemedicine.
Yeah, in an integrated healthcare network where you have outpatient areas, you have urgent cares, you have ERs, and you have inpatient, appropriate patient movement is critical to great healthcare. And so when you have tests that can affect that movement, i.e. you're in an urgent care and there's a set of symptoms and you really want another piece of data that you can rely on to say, this is fine to handle in the urgent care, or we need to move this patient to the ER. Same thing, you're in the ER, do we need to admit? If there's a rapid molecular test that fits into that space, it's another piece of the data. That data is going to be used with all of the symptom data, diagnostic algorithms to be able to make the most appropriate choice. And historically, in the sort of early days, if you're running a multiplex pathogen panel, we'll see you in 2 days, right? You can't use that in your decision-making algorithm. Whereas now the future is you may have that data and actually affect that patient movement more appropriately.
Yeah, one thing I think this is going to sing to your heart, Dr. Patel, is most of the time whenever we think about molecular diagnostics at point of care, really the intention is to have tests to treat. And sometimes, most of the time, people, when they want to walk into a doctor's office, they want to come out with a prescription. So how are we using the results for molecular tests to kind of combat some of these antibiotic stewardship issues that you've experienced?
Yeah, that's a great question. Something that I've seen that I think is really cool is people making bundles. And so like you have a bundle for if the test is positive, but you also have a bundle for if the test is negative. So you can give a symptom-based relief to someone for, let's say, sinusitis, which very often doesn't need antibiotics. You can instead give them a nasal decongestant, an NSAID, some of the stuff that will help them feel better.
So when we think about what are all of the things that we have to do or the processes that we have to implement in our labs to bring point of care in, I think that sometimes it can be frustrating because it feels like it's just obstacle after obstacle. And so there was a really great talk yesterday in which lots of people were saying we need to learn from each other. We need to share in our failures, we need to share in our successes. So Dr. Garner, I know that you have been successful in implementing molecular PCR at point of care. What are some of the obstacles that you've experienced? And, most importantly, how have you resolved them?
Sure. Molecular testing is a challenge, right? For all of us professional laboratorians, molecular testing is the kind of thing that's so exquisitely sensitive, it's easy to contaminate, and it's usually more challenging than antigen testing, right? There's going to be more steps. They're going to be a little bit harder to follow. So one barrier that I saw right away is that the clinics don't want to run it because they're intimidated by it. right? It's this setting of it's outside of their normal practice. There's a lot of steps. I'm in there telling them, don't contaminate everything. So I think there's a level of education that needs to go around the devices that are CLIA waived and that they can be used in these settings, that they can be learned. Some of this, though, is on the manufacturers, right? Just because you got CLIA waiver doesn't mean you made an easy test. And so they need to be easy. They need to be systems that you can't easily contaminate. And I think that will help. The other challenge is around the reimbursement space and the cost space. So antigen testing is less sensitive, but it's also cheap, right? The readers are cheap. Each individual test is cheap. Whereas when you move into the molecular, especially if it's going to be PCR driven, then there's a potential log-fold increase on what's going on overall from a cost perspective, and you have to show value then for that cost. This is why I don't know if point-of-care molecular is appropriate everywhere, but in the settings where you have patients that really need it, it is the best test, and there you can start to show that patient benefit that argues for the cost on the other side. Now, reimbursement is a complicated issue, and there are a lot of different reimbursement models. We have run into some challenges around reimbursement in the setting of point of care, but we've also run into some things that made it an advantage to put point of care in on the molecular side. So that one's complicated, but I think that there are a lot of issues that are, the point of care molecular tests are getting better and better, and so I think that they are starting to address some of these issues.
Yeah, and I think that something that you spoke to that resonates for everyone here is that there's kind of a paucity of data really showing what the health economic impact is of some of these. And so there's really a call to arms for us to publish our data. So as we're thinking about, how to supplement our understanding or our ability to have molecular or PCR at the point of care. What are some of the studies or the data that you want to see as a laboratorian, and Dr. Patel, what you want to see as a clinician to kind of help build that awareness and support for the science?
Yeah, I think that's a great question. I will say that, in antimicrobial stewardship research, we're all at different phases internationally. So I work with some programs in India, and we were able to publish really kind of simple what would be something that would have been maybe published 20 years ago in the US is still really important in a place like India, because then it can be modeled in different places. And the same thing applies here. So don't think that what you're doing doesn't matter or can't be published, because I think that being able to replicate what worked, what helps with some of these obstacles, what algorithms you've used in your hospital to improve the testing can be used again and again and again. And that's a really good way to kind of amplify your work.
For me, at this point, it's about medical outcome studies. So I think we've, with PCR, tackled this understanding that the PCR test at the point of care will be as sensitive and specific as the one run in the clinical lab. And we spent the last 10 years doing that. So now that that's proven, this is really about medical outcomes. So you put that PCR in that urgent care, in that ER, did it affect admission rates? Did it affect ER diversion? And prove that and attach the cost to it. So now when we go to our hospital systems to say, we want to justify this increased cost, here's this paper from this equivalent institution that showed X dollars of savings, and I think this is what we can expect as well.
Nice, thank you. So we have lots of options, and we've talked a lot about respiratory and how we can apply our molecular point of care assays there. But we always are looking to innovate. We're always looking to the future. So now, as we've kind of ironed out what the technical specifications of the technology is, how do we apply that moving forward? Like, what is the future of point of care, specifically having PCR there?
Yeah, one thing that we can definitely think about, something that's super common that we don't just treat in infectious disease, but we treat in internal medicine and public health clinics, is STDs, right? And unfortunately, we've seen so much drug resistance in STDs, partially because we empirically treat so many of these infections. So actually being able to get STI testing to point of care in places like public health clinics, which maybe are not always at the table, could really make a huge impact, not only in America, where we have a lot of resistance, but really internationally. So I think that's really important. And then again, I'm really passionate about trying to improve antimicrobial resistance at an international level. So I think, as we move forward in molecular diagnostics and in the US and in Europe, trying to move that out into places that are just building stewardship programs so that we can pair improved access to diagnostics with new antimicrobial stewardship programs. You're going to see a lot of impact from that.
Dr. Garner, you have anything to add to that?
Yeah, I mean, I really love this notion of equity and access, right? Even in the United States, I think we learned through COVID that the communities that were the most hard hit with COVID are the communities that were the most underserved and had the least availability to diagnostic testing. And so as we think about those communities spread across this country and the increase in the number of people that are experiencing homelessness, having challenges in their community, making accurate diagnostic testing available, not requiring a large laboratory or even a large reference laboratory, can truly impact care in the United States. So for me, I love the future about what directions it's going to go, but we can even take what we have now and make it more available. But it needs to be cheaper. So I know you don't set the price, but overall, I think we need to work on bringing down the costs of these PCR tests, which PCR has been coming down over the years, right? 20 years ago, a PCR test was absurdly expensive. Now it's less expensive. I think as the technology drives that cost even lower, we make it even more equitable from an access perspective.
Yeah, and I think that, one of the challenges with the point of care space is that it's so diverse. And now that puts this educational impetus to make sure that we are driving that awareness, but that everybody feels prepared and competent to be able to even interpret the results. So, as we're thinking about how we can continue to drive that awareness or even that preference in these different situations or different settings, do you have any advice for people who are kind of looking to bring this in of what are the conversations that they need to have, or who are the stakeholders that they need to bring in to make this a reality?
Yeah, I will just add that, just basically in antimicrobial stewardship and infection control, we've been trying to build resources for building a business case just in general. So there's some really open access resources from SHEA and IDSA of how do you build a business case. So I think those can be really helpful in partnering and really talking about the research that you were talking about that can help you build your case.
Yeah, I also think it's important that lab and lab leadership get out of the lab. Right, so I think the challenge that historically we've looked at our labs as only what happens in our brick and mortar buildings, and I think as point of care becomes more and more important to health systems, laboratorians, we need to take that on. Even if we're not the ones running the tests at the endpoint, we should be the ones doing the training. We should be the ones at the table bringing together the stakeholders so that we can have a lab professional eye on the types of tests that are being performed and how they're being performed, because I've noticed even in my own system, when that happens, it goes better. And when that doesn't happen, when lab is excluded and point of care tests are brought on, they call us 3 months later and say, can you fix this for us, please? And so I think on the front end, if we're able to do that, it really helps with this expansion.
Communication is always the key, right? Yeah. Okay, great. So I'll take a couple of minutes if we have any questions from the audience for our panelists.
Thank you for the wonderful discussion. So my question is on the cost, right? Can you speak to, because normally when we look at cost, we look at the upfront cost of PCR. Can you guys speak to the further cost if something is missed, right? If you're not able to detect it early, and then, so what are the outcomes and the buildup of cost when something is missed early on? So I'd like to hear your take on that part.
I will just say, what's really tough right now is I wish in an ideal world that you get the technology and then everything improves. But in many of the publications, you see that a group takes on a new diagnostic and then nothing changes, right? And so that's not great. So that means there's some miscommunication between the test result coming back and then the interpretation and then the clinical team, like doing something to help the patient, whether that's, giving the appropriate antibiotics or not giving. So I think that is where the stewardship team and the microbiology team can really work together and how you can replicate best case scenario, but often that's not the case. And so it's really something to think about as you do take on a new diagnostic.
Yeah, the success story that I always point to is the one about tuberculosis, right? I think it was always more expensive to bring on a TB PCR. We brought out a TB PCR, and there was this huge cost to the lab, but then we were able to compare that to the amount of time a patient spent in an isolation room before you knew whether or not they had TB, and the math worked out in our favor by far. But it couldn't just be looked at then as a lab cost center. It had to be looked at across the entire system. And so that's really where the communication and the team effort comes in. And if you have the right team collected, team of lab, but then team of clinician, team of administration, now you can come up with the right financial solution, because in honesty, the lab's not gonna make that money back. We're not, and that's not our job, right? The lab's not there to make money. The lab's there to affect positively patient impact so that we can then save money on other and make people healthier.
Yeah, that's a great example. I think a hospitalist would be the person who would actually be able to, so that's someone you may not always have at the table, but so being broad in the team is always helpful.
Any advice? We're about to go into respiratory season. Any advice for the people in the audience about how to prepare?
From a lab perspective, we're gonna try and test for as much as we can. And so I think the standard test going into the season will be a COVID, flu A, flu B, RSV test. Because in that setting, you have kind of everything, because we don't know what's gonna be first and when it's gonna come up. But clinically, that's tough. That's for you.
Yeah. I mean, I think I've done a lot of media interviews over the last few years, and like my message has not changed, even though so much has changed. And that is to get vaccinated, get your family vaccinated. You know, all of us can have an effect change within our own like circles. And so getting more people vaccinated is always the key.
Perfect. Thank you.